I am Dr. Sharjeel and you are watching my YouTube channel. Now here we will discuss and solve the challenging case 187. Now it was a straightforward case and the pathology was in a horizontal case. There was limited abduction of the left eye and almost every comment was spot on that it's a case of acquired sixth nerve cranial palsy. Now as the sixth nerve supply ipsilateral lateral rectus which abducts the eye, so the sixth nerve is also known as abducens nerve. Now when it is paralyzed, the eye could not move laterally and result in esotropia in primary gaze and inability to abduct the eye fully. Sometimes you get bilateral sixth nerve palsy. Then you must check the fundi for papilledema, bilateral disc edema, because raised intracranial pressure can lead to pressure on the sixth nerve during intracranial course, leading to bilateral sixth nerve paralysis. As soon as you lower down the intracranial pressure, the paralysis reverses, so it's a reversible sixth nerve palsy. Sixth nerve, like a fourth nerve, is a long slender nerve and it is prone to trivial trauma. I have diagnosed sixth nerve palsies with patients falling off from the bed during sleep, when the teachers slap hard the students on the face, on the side of the face. So trauma is also one of the common causes of sixth nerve palsy. You must ask about trauma in history. And the next most common is the ischemic sixth nerve palsy in elderly patients who present with sudden double vision, horizontal diplopia and inability to abduct the eye. You should ask about diabetes and hypertension and their control. Tumor, demyelination and infection of the brain can also cause sixth nerve paralysis. So these are the common causes of sixth nerve palsies, and it can be congenital as well. And congenital, there will be no diplopia, whereas in acquired there will be diplopia. And when a patient presents with a squint and double vision, it means that it's a paralytic squint. Now patient presents with a double vision, diplopia is horizontal, so you perform extraocular movements and there is abduction defect. Diplopia and motility is restricted, maximum in the direction of paralytic muscle and minimum in the opposite gaze. Secondary deviation is also greater than primary deviation. Now what is meant by primary deviation? When the patient fixates a target with a normal eye, now that is called primary deviation. And when the patient when you cover the normal eye with occluder and tell the patient you should cover it with a transparent occluder and tell the patient to fixate with the deviated eye, that is when secondary deviation can be observed in the normal eye under transparent occluder, and the normal eye will show lot more deviation than the abnormal eye according to Herring's law of equal innervation, because now the paralytic eye needs a lot more energy, lot more power to fixate. So after the diagnosis, you should advise Hess chart. In the initial stage, you should patch the deviating eye to relieve the sudden onset worrisome diplopia, and you should treat the cause, and you should perform Hess chart, and you should follow the patient with the 3 monthly Hess charts, and when the changes of the 2 Hess charts 3 months apart are same, and there is still some deviation, and there is no further improvement in the deviation, then you can go for a surgery in which the superior and inferior recti, they are split in half, and they are then attached with the lateral rectus to give some lateral movement and correct the deviation in primary gaze. Usually the sixth nerve palsy patients, most of the patients, they don't need surgical corrections, and it completely resolves. The other treatment options are prisms in glasses, as well as Botox injections in the contralateral muscle. So that was all about the abducens nerve paralysis. I hope you learned something from this video. Thank you very much. This patient had ischemic sixth nerve palsy.